Maybe tell you a little bit about how we provide services and how this relates to assisted outpatient treatment. Because we were providing services before Kendra's law was enacted and after, and most of the services we provide in our agency are through either a sort of community treatment or intensive case management with housing as a first service. This issue of Kendra's law, Kendra Webdale, and the labeling and the power of labels and the kind of tradition that even this law is named after keeps alive the sense that people with mental illness are dangerous. Kendra was killed by a push from a man who was very psychotic, Andrew Goldstein. And Andrew Goldstein, I don't know if any of you remember this, had sought treatment in New York's emergency rooms 11 times the year, same year that he pushed Kendra. We don't call this law the system's failure of Andrew Goldstein's treatment, which would have had a very different feel to this whole conversation than about Kendra's law. And the ACT teams were implemented, and AOT clients got priority on ACT teams. We have two very different parallel streams going in the mental health system, and Commissioner Hogan isn't responsible for those, they preceded him. But on the one hand, we had all of this recovery language, the Freedom Commission report, and how do we do all this consumer-driven and family-inclusive treatment, and at the same time, we had this push to monitor and watch out for people, almost like a mental health probation officer, and the same person inhabiting the same role, working on the same ACT team. From a provider's perspective, that is a very complex task, and not one in which people are trained or that there's enough discussion about. It is philosophically confusing, not only to the clients that we're serving, but to the staff themselves. People come up with AOT orders, and we're told we have to make sure they're taking medication, and you hear the data. Do they have medication? Are they taking it? Do they have it in their pocket? And we also have to drug screen them. We have, from the very beginning, run a program that's all about consumer choice. We have to essentially change our program philosophy and pay attention to those two things that the AOT order is looking at. Now, those of you that know about engagement, and I know most of you do, you want to engage the person where they're at. Most people are not about, let's do a drug screen and let's see if you're taking medication. The order actually pushes against a useful, helpful, constructive engagement process. The order itself is rigid. Either the person is compliant with medication and not taking drugs or not. If the person is taking medication, but they need to go to the hospital because they're not doing well clinically, the order doesn't allow for it. You can't get AOT to intervene to hospitalize someone even if they need it. If the person is not taking medication because the provider agrees that the person's doing well, AOT will insist on a hospitalization because the person's not compliant with the order. It's like a bad managed care company that is actually interfering with the treatment of the person you're working with. How do you do that? For the people that need AOT the most, non-compliant, when the order expires, if they don't show up for 3 appointments to renew the order, they're dropped out of AOT. The very people that possibly need it most are getting lost in that process. We heard the study, we heard the data. It seems sort of interesting when I get out of it. AOT does push for an engagement with ACT or ICM, much more likely to get services if you're on AOT than not. That's a good thing. It's not exactly an evidence-based practice. If we look at the evidence-based practices, if we look at supported employment, if we look at IMR or IDDT or ACT or any of the alternative kinds of treatments that Mike Hogan mentioned, we would know that evidence-based practices, all of them, are emphasizing consumer choice. And consumer choice does, we know from the data, lead to increased mastery and lead to a reduction of symptoms. And that's where we should be looking at, the kinds of things that improve consumer choice to reduce symptoms. Thank you.